first report is called Invisibility is Killing Us, Data Aggregation and Its Health Impact on Pacific Islanders and Asian Americans in California, funded by the US DHHS Office of Minority Health. CAUSE was invited to join this collaboration earlier this year, or the end of last year. And I'm going to invite up Cevadne Lee to talk more about the report and its findings, and then we'll hear from community leaders about how they work inside our communities and the impact that they have. So Cevadne, come on up.
I'm short. Okay. Hi, everyone. I'm Cevadne Lee. Can you hear me? Okay. I'm the principal investigator of Southern California Pacific Islander Asian American and Data Equity Health Policy Collaborative, a project funded by DHHS Office of Minority Health. Today I will share with you our project findings that are detailed in our report, Invisibility is Killing Us, Data Aggregation and Its Health Impact on Pacific Islander and Asian Americans in California. If you'd like to follow along, please scan the QR code on the screen. We also have physical copies in our table over here if you don't want to look at a tiny smartphone. Does data disaggregation benefit Pacific Islander and Asian Americans in California? That is the undergirding question for our project. Oops, sorry, went too far. Okay. The problems of race ethnicity data collection did not start during the COVID-19 pandemic. They started all the way in the formation of this country. To better understand the structures that create inequitable data, we have to examine our country's sociopolitical history of data policies. The two policies in bold in the middle are the two policies we examined. Communities saw the impact of the 1997 OMB policy, but also California's elimination of affirmative action. The elimination of affirmative action in California has had profound impact, not just in education, but also in the distribution of public health resources. Embedded in this 1996 ban of affirmative action also states that race and ethnicity cannot be used as a factor in the distribution of state-funded resources, including state-funded health programs. Native Hawaiians and Pacific Islanders in Los Angeles County were dying from COVID-19 5 times more than all racial and ethnic groups. But that data and information was not factored in state COVID-19 resources to NHPIs living in LA County. But we persisted in advocating. After 27 years of advocacy and this grant opportunity, we finally have revisions to a federal-wide Office of Management Standards for Race and Ethnicity, also known as OMB 15. From 2021 to 2022, we conducted a legal mapping study to analyze the practice of data disaggregation at counties with a population of 106,000 or more. Legal mapping is a specific method under legal epidemiology that analyzes the state of the law or policy concerning a particular legal topic. Our legal mapping process included analysis of federal and California state policies and standards adoption at local health departments. California does not have its own policy or standards to guide our health departments on collection of race and ethnicity data. 6 local health departments developed their own standards for collecting race and ethnicity, LA County being one of them. 11 health departments reported that they follow federal policy, and 24 health departments without a standard reported using state or federal data collection systems. And I will point out that only Solano County Health Department disaggregates data further by subgroups following state data disaggregation policies 8B 1088 that was passed in 2012. And I want to thank the sponsor for this bill, Honorable Mike Ang, who's here today, and I'm so pleased to meet you and the impact that you have had with that bill and how it's being implemented. But sadly, only one county is implementing that policy today. Oops, too far. With help from the UCLA NHPI Data Policy Lab, we adapted their Community Needs Assessment Questionnaire. With help from our steering committee, we surveyed 200 NHPI Asian American organizations, ethnic media, and philanthropic institutions in California, with a primary focus on organizations in LA and Orange County. The question themes we asked are, where do Pacific Islander and Asian American organizations find race and ethnicity data? How do they use it, and what are their data needs? The majority of the community organizations we surveyed relate that the top barrier for accessing race and ethnicity data is that the information is aggregated or put in the other category. Respondents also conveyed that the top need for race and ethnicity health-related data was to apply for funding. Next, I'm going to have our 3 speakers who will share stories or case studies about the impact of data and equity. And first is Isa Sasi from Southern California Pacific Islander COVID Response Team. If you want to use the microphone.
Hi, everyone. I'm very grateful to be part of this data report and just to be able to highlight what our Native Hawaiian and Pacific Islander communities have been facing throughout the pandemic. With what's considered a small population, but was highly affected by COVID-19, our community, it felt like we were losing our loved ones almost every other week. And do you have a paper? Do you have the actual paper?
It's behind you.
Oh, it's behind me. Oh, this is my story. Okay. Anyways, so one of the hugest barriers that we had to face was isolation. And the hard part was one, we had to isolate ourselves, and 2, our loved ones were dying in isolation. So with the community that values communal spaces and that leans on each other during hard times, we basically weren't able to practice our cultural values. We weren't able to greet each other with hugs, cheek-to-cheek greetings, and in the Chamorro culture, they basically have the youth sniff their elders' hands. And one of our Chamorro community leaders, Heidi Cuenga, she basically said it was really hard for her to tell the youth to stop doing that because it basically symbolizes taking in an elder's wisdom. And because we were losing so many people during the pandemic, it was basically a burden for us to tell our community to stay home or to wear masks or to stay 6 feet apart, and to tell them not to go to church, stuff like that, or like even have food gatherings. And for a while, it was a burden for our community leaders to learn how to advocate for our community at that time, because there's no protocols or data for Native Hawaiian Pacific Islanders to follow when we're in this public state of emergency. So when it came to isolation, another thing was that we weren't able to grieve together and, practice our gift exchanges when it comes to supporting our families that are grieving. And because we lost a lot of our elders to COVID-19, it created a lot of waves of emotions. So a couple questions that I do want to highlight for y'all is, how much longer will it take, or how much longer do Pacific Islanders have to suffer before we get the help we need? And how much longer will these public agencies continue to use insufficient data to justify not prioritizing us as a group? Thank you.
Thank you. And then next, I'll invite Dr. Brittany Morey from the University of California Irvine School of Joe C. School of Population and Public Health.
Thank you. First of all, just congratulations, Cevadne, on this amazing report, and thank you so much for sharing such heartfelt stories, Isa. And yeah, thank you all for being here. I'm here to share about some of the work that we did during the pandemic with my collaborators, Drs. Lorraine Escobedo, Melanie Sabata-Liwag, and Nines Ponce. And during the pandemic, the data in most counties throughout the United States were showing that Asian Americans were not dying at high rates from COVID-19 compared to other communities of color, and sometimes also compared to white communities. But from the stories that we were hearing from people in communities and on the ground, that we knew that this was not across the board the truth, that this was not across the board what was really happening. And one of the communities that we were really alerted to the issues in was the Filipinx community. And this was, coming out during the pandemic. We were hearing reports from the community, from news reports as well, about how Filipinx healthcare workers in particular were really bearing a brunt of the COVID-19 pandemic. Some of them coming out of retirement in order to fulfill healthcare needs, some of them working extra shifts in order to, respond to what they felt was an emergency that they were needed in. And suffering from high rates of mortality as a result. But this was not being shown in the data. The one state that had disaggregated data for Asian American subgroups and also Pacific Islander subgroups was Hawaii. And so looking at the data in Hawaii, we saw that Filipinx communities were one of the highest, had one of the highest rates of mortality behind Pacific Islander communities. And so we thought that this might be the case in other states, but we just couldn't see it because it wasn't disaggregated in the data. So what did communities do kind of in this void, this absence of disaggregated data? There's this website called Kanlungan, and Kanlungan is a Tagalog word for refuge. And they were basically crowdsourcing data to document Filipinx healthcare worker deaths. And so they were going through obituaries and finding out about these people who had died globally, and they were mapping them and telling their stories and paying tribute to the sacrifices that they made. And these aren't just nurses and doctors, these were also people working, in just behind the scenes or, servicing in the healthcare industry. And so we were trying to figure out how do we better represent what's happening in the communities in this absence of data. And so we had to do basically this data gymnastics to try to figure out, what's going on in the Filipinx community. And so what we did was we took data, we looked at the counties that had data for Asian American mortality. And we combined that with census data to show, okay, what percentage of the Asian American population are Filipinx? And we also were able to say what proportion of the healthcare workforce in that county were Filipinx. And we were able to show that in counties that had a higher percentage of Filipinx people making up the Asian American population, that the Asian American mortality rate was actually higher in those communities. And we also found that when Filipinx people were making up a larger share of the healthcare workforce, that those counties were also having higher rates of mortality amongst our Asian American population. And so, this kind of shows the costs. We have to go through all this gymnastics, all these hoops in order to show anything that's going on in our communities when the data are not disaggregated. And so that's a problem that we really need to solve. And so, it just goes to show the importance of disaggregating data. So, thank you.
Thank you, Brittany. Next, Peter G. from Little Tokyo Service Center.
Hi, everyone. My name is Peter. I'm with Little Tokyo Service Center. My pronouns are he and him. I really want to thank Cevadne for letting us be here and to just share the space with such incredible folks. So our organization has started a youth mental health outreach program in the AA and HPI community called Changing Tides. And the origins of Changing Tides was really young people kind of coming together saying that the mental health needs of our community are getting ignored. So last summer, actually last spring, the California Department of Public Health released a request for proposals to the community to do youth suicide prevention. And it was a great proposal in many ways because it created targeted special populations that the RFP was supposed to serve. And unfortunately, the only community that was not included in this $16.3 million RFP was the Asian American, Native Hawaiian, and Pacific Islander community. And we were really frustrated at this oversight because a lot of us know that this is a huge issue going on in our communities. And so, we reached out to CDPH to meet with them. And when we met with them eventually last summer, they essentially told us that there wasn't enough data to prove that enough people from our community, enough young people, were dying by suicide. when they looked at the master death files which was the data set that they used, that there weren't enough. But that was very contradictory to what a lot of us are seeing every day and all the stories that we hear. And so we continue to kind of push back to CDPH, providing alternative data sources that show actually when it comes to accessing mental health, the A and HPI community are overlooked. And we also provided lots of other data showing that suicide is a huge issue. And there's some stats that our colleagues put up on the slide that kind of validate that. But it's taken over a year for us to have follow-up conversations with CDPH about this, and I'm really grateful to be joining forces with SoCal PCERT, Asian Resources, Okapica, REMCO, and many other organizations across the state to really push to keep CDPH accountable for this vast oversight. And we're also really grateful to my colleague Erica, who kind of was able to work with Cevadne to kind of put together this case study. But just in closing, to share a little bit about the day that I had with you yesterday, I spent 2 hours with some survivors, family members of 3 young people in our communities who passed away within the past 3 years. A family reached out to us recently just to connect to other parents to figure out how they were surviving and managing their grief. And so I'm sitting here with my colleagues, hearing the stories of many differences but many parallels of young people in our communities that everyone thought was okay, but that they were struggling, but yet they died by suicide. And these stories of these parents and the caregivers, just are so poignant. And I know there's lots of people in the room that probably know someone or know someone of someone that has died by suicide in our community. And so it's really frustrating that the California Department of Public Health, which is an agency that is supposed to protect the public, has been ignoring our communities, and it's why we really need to advocate for our communities to make sure that we are not forgotten when it comes to public funding to address these issues in the long term. Thank you.
Thank you, Peter. In addition to the data inequities faced by our 3 speakers, they also play out in anti-Asian hate. In 2020, while I was on the board of Southeast Asian Community Alliance, a nonprofit based in Chinatown, Los Angeles, we saw the urgency of getting Chinatown seniors tested for COVID-19, particularly seniors that were living in single-room occupancies. We finally were able to get the mayor's office to set up a one-day testing clinic. Despite calls to community members, hanging door signs, knocking on doors, less than 10 local residents showed up. This was a reminder to me as a healthcare worker and a public health researcher, the fear associated with COVID-19. From just walking to the clinic and fear of getting attacked, to others knowing about being COVID positive, and also how it impacted the lack of data around COVID-19. No data, no problems, to no resources. These personal stories are why we came together. This is not a story about data. This is a story about communities mobilizing, responding to the invisibility, and demanding changes in a system that does not see us. We are the communities who care. We are Pacific Islanders, Asian Americans, public health workers, researchers, community-based organizations, epidemiologists, community members, immigrants, refugees, survivors, data warriors, and we care. What is data equity in comparison to data disaggregation? Data disaggregation is a term used to refer to the collection of data. Data disaggregation can be the collection of and reporting of groups by race, ethnicity, sexual orientation, gender identity, disability, income, region, veteran status, or other meaningful demographic variable. We define data equity as data that is collected, analyzed, interpreted, distributed so that invisible communities have access to and can use this data. Part of data equity is centering communities. We were intentional in leading with Pacific Islanders. Too often, Pacific Islanders have faced inequities when they are aggregated after Asian. These are the many community-serving organizations that have been mobilizing. The community leads of this project are in the box on the left. With each We each facilitate or participate in 2 data equity coalitions. The coalitions are comprised of community-based organizations, FQHCs, cultural organizations, language immersion schools, county health department staff, academic researchers, civil rights organizations, civic engagement advocates, and more. Our findings informed our recommendations to the California Department of Public Health and also county health departments to work together in partnership with communities. The diverse ways local health departments implement race and ethnicity data collection and reporting is a systemic issue that needs to be addressed at the state. We can work together to advocate for better data, and we need our elected officials who are here in the room to invest in health department infrastructure and also to continue investing in our communities to work with local health departments on data equity. Data desegregation can also benefit our communities, as in the example we have in our report about disaggregated cancer data informing culturally tailored Vietnamese information about hepatitis B and liver cancer. However, this example is the exception, and there are few and far in between to find other similar examples. Missing a slide. In my previous example about hepatitis B and the Vietnamese community, that wouldn't have been made possible without our true data champions. So I want to acknowledge our pioneers who really did the work around data disaggregation advocacy, all the way starting from the 90s with the first article about data disaggregation and its health impact, to all the way to these community reports that were developed 20 years ago documenting data disaggregation. I want to thank these pioneers for the work that they've done, because we wouldn't be here today without them. These are the many community organizations, partners, and steering committee. Some of them are here today. I want to thank Erica, who's our evaluator from Special Service for Groups. You want to wave your hand, Erica? I want to thank our community partner, Cause, who's hosting us today. Nancy, thank you so much. I especially want to thank my right hand, Melanite Fifita. Wave your hand. In addition to being an amazing research associate, she's also a patient navigator and also connected Cause to the many plants that you're going to see outside with the local Tongan community nursery. So thank you so much, Melanite. And did I miss any of our community partners? Oh, and Priscilla from Center for Asian Americans in Action, one of our community partners that are here today as well. Thank you to the Office of Minority Health for being one of the few funders who funded NHPI and Asian Americans during the height of the pandemic. Lastly, I would be remiss if I didn't mention that the funding period to support this research and advocacy ends next month in September. As a demonstration site from the OMH, we have been tackling health disparities that contribute to structural racism. But this work doesn't get solved in 3 years. Continued investments in our community is paramount. Our findings, our stories, and our recommendations are in this report. How can we work with you, the elected officials, to ensure continued investments are coming to our community-based organizations and health policy coalitions to implement our recommendations? Circling back to my earlier question, does data disaggregation benefit Pacific Islander and Asian American communities in California? We want to hear from you. Thank you, and we'll open up to Q&A.